All right, welcome back, everyone. Thank you so much for joining us for the public comment portion of our meeting. We will not be having the Innovation Spotlight, but we are having public comment this go around. And please be sure to register for the next meeting in May if you'd like to present during the Innovation Spotlight portion. So for our public commenters, thank you so much for joining us on time. We appreciate your attendance. Please note that you have 2 minutes to provide your public comment, and you're also welcome to send everything to our CARB, C-A-R-B, at HHS.gov mailbox, which will be shared with the rest of our council. I would first like to start things off with Dr. Keith Martin from the Consortium of Universities for Global Health. Dr. Martin, the floor is yours.
Thank you very much. So in my 2 minutes, this is my intervention. We actually know what to do to address AMR. Political commitment, train people, rules, regulations, and enforcement and infrastructure. Second point, don't reinvent the wheel. Work with existing structures. The quadripartite agreement between the UNEP, FAO, World Health Organization, and the World Organization of Animal Health have developed a global action plan. There are also national action plans that countries have actually signed on to, with a monitoring system and a system of self-evaluation that happens every year. Support that. Second, capacity building. And the capacity building, particularly in the public service, because you cannot address this without having the capacity within the public service, not only in health, but of course in agriculture, infrastructure, public works, the environment, industry, and justice. How to do this. Strengthen your health attaches in your embassies. One of the gaps that we have at the Consortium of Universities for Global Health, and we have 190 academic institutions around the world, is we lack the intel to know what countries are actually willing to put the political commitments and resources in to do this. We also don't know who to speak to. Use your health attaches to identify those people, build those partnerships up, and work first to be able to strengthen their own academic institutions within their public service, and then buttress that with U.S. academic institutions and the CDC. And that involves having a pipeline to the CDC and U.S. academic institutions that can actually channel capacity building capacity with capacity building needs. Next point is to engage professional associations, not only in my profession in medicine, but veterinary medicine, nursing, farm, etc. You need to share clinical guidelines, not only in the clinical use, appropriate use of antibiotics, but also in waste management. It's critically important for not only humans, but also animals and the broader agriculture base, including aquaculture. And finally, you can create a platform of best practices that can be open access, make it available, put it online, and that would be a very productive and effective mechanism to share the knowledge necessary to be able to address this leading cause and leading threat to global health. Thanks very much for your time, and we're happy to help anytime. Bye-bye.
Thank you, Keith, for joining on behalf of CUGH. Appreciate your comments. Next I'd like to invite Hannah Friedman from the Boston Children's Hospital.
Hello, everyone. Thank you for your time. Brief background, I'm about to start my PhD in microbiology and immunology with a special interest in AMR research. I would like to highlight some additional challenges and perhaps ideas the U.S. government should continue in this future fight against AMR. First challenge, we need more funding within the public health sector. An analogy that can help put things into perspective, our Public Health Defense Department is the HHS. However, this budget is merely a fraction of the DoD's budget. How can we expect the public health sector to not only do its job, but also recruit the next generation of workers to this sector if there are minimal to no employee benefits? You cannot work efficiently nor effectively if your employees feel overworked and undervalued. Second challenge, the lack of public health infrastructure. For example, the development of a real-time database. I was shocked to hear how Dr. Walensky was receiving critical data while managing the COVID pandemic by a fax machine at times. This type of repository could both save valuable time and offer critical life-saving epidemiological data that can then be leveraged for evidence-based policy and clinical decision-making. Third challenge. We currently live in a highly polarized political environment. It is unfortunate to witness how politics influence something as fundamental as human health. I wrote a systematic review arguing how political affiliation may now be considered a social health determinant. While I do not have a solution to this issue, there needs to be some separation between politics and healthcare. Maybe this includes having a separate agency like the CDC director instead of the president or Congress. Maybe have messaging coming from just state and local public health workers instead of political leaders. I'm unsure. Fourth and final challenge kind of ties into the third: effective messaging to the public who may not understand the dynamic nature of scientific research, and to have effective messaging when dismantling mis and disinformation in a very sensitive way. Let's look at vaccine hesitancy, for example. At the end of the day, it does not matter how ridiculous you think a person's rationale is. The fact is their fears are real to them, and if you want to influence their behavior, it is the responsibility of the educator, whether that is the government, scientists, doctors, whoever, to meet the public at the boundary of their knowledge. Thank you.
Ms. Friedman, thank you so much for your honest comments and good luck on your PhD. All right. Dr. Kim, thank you for joining us on behalf of the American Society for Microbiology. Go ahead, Wes.
Thank you. Good afternoon. On behalf of American Society for Microbiology, we appreciate this opportunity to provide comments on gaps, challenges, and opportunities to combat AMR, specifically in low-income countries. AMR disproportionately affects LMICs, yet many of these countries lack the infrastructure and resources to perform surveillance required to assess AMR. According to a recent study by the African Society for Laboratory Medicine, only 1.3% of the 50,000 medical laboratories across 14 participating countries conduct bacteriology testing. That same report noted a shortage of 850,000 laboratory workforce in that continent. A 2018 Lancet report by Ambassador Nkengasong highlighted the lack of accredited laboratories in Africa. Furthermore, many Latin American hospitals lack resources to establish stewardship programs. ASM's Global Public Health Program strengthens laboratory capacity in resource-limited settings and empowers microbiology laboratories to integrate clinical care and population surveillance. This has resulted in accreditation of laboratories and increased data submission into global databases for both human and animal health. Stewardship and other measures to combat AMR are most successful within the context of strong public health systems. Laboratories are the backbone of public health systems. Addressing AMR will require multilateral commitments to public health and laboratory system strengthening. Funding commensurate with global risk and impact is needed. The U.S. must continue investing in global programs that strengthen health systems and build laboratory capacity. For example, with funding from CDC's Global AR Lab and Response Network, ASM currently supports programs in Mexico and Brazil to improve the detection of AMR threats. The same global network also responds to AMR threats and informs global prevention strategies. Financing R&D of medical products and diagnostics for disease endemic in LMICs is another challenge that warrants more attention. We need end-to-end policies that catalyze both R&D of novel medical products and equitable access for and uptake by global populations. In closing, ASM appreciates PACCARB's commitment to amplifying these concerns. We stand ready to help. Thank you for the opportunity to provide these comments.
Thank you for joining us, Wes, on behalf of ASM. Next, I'd like to invite Dr. Patrick O'Carroll from the Task Force for Global Health.
Thank you very much. There is surely no need to mention to this group that AMR is one of the most important and pressing, and also one of the most complex global health challenges that we all face. It's our experience at the Task Force for Global Health that all large-scale global health challenges, by their nature, require carefully assembled, purpose-driven, target-driven coalitions of many people and organizations at many levels to effectively address a given challenge and guide collective efforts to reach specific targets. I believe AMR is no exception to this general truth. And frankly, as Keith Martin indicated in his comments, many elements of such coalitions are already in place, such as national plans in many places. But from today's presentations and discussions, it's also very clear we have many wonderful people and organizations at many levels, including WHO and the US government, creatively working on various aspects of the AMR challenge. But I believe there is still a clear need to build on current efforts to ensure more deliberate and active global coordination of these and other efforts through a set of carefully conceived, well-organized, goal-driven coalitions with clear targets and data-driven accountability in order to make the most of the many efforts we've heard about today, already underway and others, to address this extraordinarily complex challenge, and to ensure real action and measurable progress at the community level all over the world in the many dimensions of this AMR challenge that we've discussed today. That's not an easy thing to do, but that approach, this data-driven coalition approach, is the one that has given us remarkable results here at the task force in addressing challenges such as getting vaccines to children all over the world, eliminating certain tropical diseases, and strengthening health systems. And thanks for this opportunity to share that perspective with you. The task force stands ready to help the global community however we can in this regard. Thank you.
Thank you, Dr. O'Carroll. Next, I'd like to invite Vikram Venkatram from Georgetown Center for Security and Emerging Technology.
Good afternoon. Thank you very much for this opportunity to provide these comments today. As today's discussion has established, the United States must fight AMR globally and domestically, since resistance developed anywhere can spread, including back to the U.S. One crucial mechanism by which the U.S. can address AMR is through its support for basic research, which is the first step towards new solutions. New therapies will be built on a better understanding of how AMR develops, how pathogens and hosts interact, and which molecular pathways could make promising targets. These discoveries will only come from a robust, diversified, and well-resourced basic research enterprise. At the Center for Security and Emerging Technology, we led an effort to assess the state of the global AMR research landscape. We found that the U.S. is one of the world's foremost players in AMR research, publishing more and collaborating more internationally than any other country over the last 2 decades. The U.S. was also home to multiple of the world's top 10 publishing organizations and funding institutions for AMR. These characteristics make the U.S. a global leader in AMR and give it the chance to shape the future of the AMR research landscape, including by supporting global AMR research. We also found that there are major gaps in the AMR research environments in much of the low to middle income world, including in countries that bear a significant burden from AMR. No countries in sub-Saharan Africa or Southeast Asia, both regions with a high disease burden, published a high volume of AMR research or were home to top funding or publishing organizations. However, countries in these regions had a high focus on AMR. Despite the low volume, AMR research was a high percentage of research on microbes. This focus on AMR suggests that these countries would benefit from increased resourcing and is further evidence that U.S. collaboration would be valuable. Based on these findings, CSET recommends that the United States stimulate critical AMR discoveries by boosting its domestic support for AMR research, including by increasing funding. Additionally, the U.S. should leverage its ability to collaborate internationally to cooperate with countries hard hit by AMR, supporting research infrastructure development, promoting collaborative research projects, and helping improve antimicrobial stewardship and surveillance. Since research is the first step towards identifying solutions to AMR, U.S. support for global AMR research could have a major impact, addressing a gap in the research landscape in keeping with One Health principles. Thank you for your time.
Thank you so much, Vikram. Lastly, John Alter from the AMR Action Fund. Welcome, John.
Thank you, Jumana, for the opportunity to provide recommendations to the Council. The AMR Action Fund is the world's largest investor in the development of antimicrobial treatments. We are committed to helping to bring up to 4 new critical need antibiotics to the market by the end of the decade. But our investments are a short-term stopgap. We need long-term solutions. So therefore, we suggest the following policy recommendations for improving international collaboration and capacities for AMR R&D, prevention, surveillance, and control. First, appoint a federal champion for AMR to represent U.S. policy positions on the global stage. Second, encourage U.S. regulatory agency engagement with drug and diagnostic developers to agree on expectations and preempt common challenges. This is especially important in low and middle income countries where executing clinical trials and collecting data can present unique hurdles. Third, streamline and harmonize administrative and regulatory processes, and work with international counterparts to foster multinational AMR clinical trials, support global regulatory networks, and establish innovative surveillance frameworks. Fourth, work with the private sector partners to improve capacity for antimicrobial R&D, stewardship, surveillance, and diagnostics in low and middle income countries. Fifth, implement subscription model frameworks for critical need antibiotics via multi-year contracts rather than volume-based procurements. Sixth, support and invest in robust AMR workforce, including researchers, infectious disease clinicians, and antimicrobial stewardship program pharmacists. Finally, enact policy that reflects access to antibiotics as a moral imperative and work to broker greater access to first-line treatments for patients in low and middle-income countries. Thank you for your leadership, and we are always available to assist in advancing solutions to AMR.
John, thank you so much from the AMR Action Fund. And folks, this closes out our public comment portion of the day. We appreciate all of you joining us and providing your thoughts. And hopefully we'll see you again in May. I'll now transition this portion to Dr. Paul Plummer so we can have some open discussion.
All right. Thank you, Dr. Musmeyer. Again, thank you for all our public commenters and our speakers for today. I think we had 3 great panels, lots of information to distill out of there. And so it's not on the agenda in this format, but as you know, we often do a round table or round robin kind of at the end. We don't have time for one as long as our last meeting. So I'm going to ask everybody to think about like a 1-sentence summary. What's your takeaway from today? And so it needs to be quick so that we can get all around the room. Those of you, so Dr. Patel, Dr. Burbick, and others online, we will come to you at the end. But I have asked my vice chair to kick it off, so that buys you a sentence to think about it at least for Dr. Patel. And so we will just go around the room here clockwise, and then we'll come online here at the end. So Dr. Newland, your take home.
Access to behavioral interventions, vaccines, antimicrobials, and laboratory services. 1 sentence.
Love it. I underlined several things that people said today. I'm just going to highlight one. One is that antibiotic literacy is low, and that, you know, up to 50% of the public in many countries believe antibiotics kill viruses. So I think of all of the things that we can do, some sort of awareness and education campaign may be the easiest. That's something I took away.
So as for 1 sentence, my takeaway is that we need to have targets to coordinate action on a global basis.
So this is from much earlier in the day, and I've heard we're talking about public health interventions of various kind is how to make it easy to do the right thing. And I'm wondering also about making it hard to do the wrong thing, and how we can also implement that sort of thought process. And maybe it's regulatory, but maybe there are other ways to make it hard to make the bad choices.
My takeaway is incredible meeting. I always leave here mind-blowing, learning so much. But one thing that I want to mention is that I didn't hear much conversation in AI, and the artificial intelligence is moving in our lifestyles every day, especially in healthcare. I'm wondering if, especially for data collection, data mining, if AI could really serve as a great tool for AMR.
So for me, our messages are not working adequately, and we need to change our language to be able to have everything across the board, but especially for me, ways to have market-based stimulations for innovation, and more innovation.
Perhaps to bridge Jason's point and Lynn's point, my main takeaway is that this space really needs a coordinated and multifaceted approach to address the challenges that prevent sustainable access to life-saving antimicrobials, both on the innovation front and bridging that access issue.
I'm going to echo the comment on targets, but I've been thinking a lot about the comment about context, and I do think that stratified targets make a lot of sense in certain layers of what people can handle at the right time.
So like Jason, I was thinking a lot about access, but I think it was Jennifer Cohen who mentioned the term antibiotic ecosystem. And so as we improve access, I think we have to be sure it's not just access to antibiotics, but also to appropriate diagnostic tools and effective antimicrobial stewardship programs that support the appropriate use with the additional access.
Learned a lot about access, listened to a lot about surveillance. I think the theme that I would take home, though, that sort of resonates with the work that ARC does is the importance of continued research and implementation on behavior at the local level, and how important it is to focus or tailor that to the local level, paired with policy levels or policy levers at a higher level, but neither works ideally in isolation.
I thought the concept of co-design was very interesting. And also when we talk about access, I was always a little bit worried about that we're going to just flood everybody with antibiotics, but I was very pleased to hear this sustainable access concept. So access along with education, stewardship, and improving the way antibiotics actually are going to be used besides the access. And lastly, I think there is a lot we can learn on better using vaccines and how access to vaccines is also going to play an important role in AMR.
What I'm taking away from today is how can we capture and how can we tell the story of all of these efforts to address antimicrobial resistance? They're really a value add for the existing work that we're doing on farms. So we're doing a lot of work on behavior change, on how do we improve biosecurity, how do we increase uptake of vaccines. We're already doing those things, but not thinking about it in the context of AMR. So how can we think about it as a value add and bring these different efforts and ideas together?
I think I'd just like to foot stomp all the comments around access. I think the development and the R&D work that has gone on globally is definitely transformational towards bringing new products to market, but without access to those products, it becomes a challenge to actually really address the threat of drug-resistant infections within lower middle-income countries.
I was most struck by Dr. Carr's comments about shifting from fear-mongering to a more positive message. And I really want to go see and look at that module they developed for kids about teaching this concept through the idea of harmony with nature and microbes.
So my take-home message is very simple: education, collaboration, and communication. Thank you.
Thank you. My take-home message is that AMR is not a disease, and that is something I think points out to communication and enhancing that power of reaching to people to understand what it all means. And the other very important thing that I learned a lot today also is about the surveillance and how do we build from successes that are already happening and take it to the next level and the next level, associating the existing information with any newer information that comes. This can be very powerful. Thank you.
I think we chuckled when the one person said we can advance AMR by not talking about AMR. But I think that just highlights communication, right? How we communicate it. So what my take homes are really are identify the drivers for decision making, context matters, and no one approach fits everything.
My take home is we do see AMR as a One Health issue, but I think we still, when we have illustrations, we still put human beings in the center, and that's understandable. But I think, AMR is also an animal health issue. We need to really talk the talk, walk the walk, and make sure that when we talk about AMR, we're respecting the fact that when animals are infected with resistant infections, not only will that be deleterious to those animals if there's no treatment for those animals, but then it could also create food insecurity and other downstream effects that do affect human beings. So that might be something that we think about in terms of communication.
And for me, it would be access to antibiotics and vaccines, as well as awareness globally, are probably the biggest issues that we will have to continue to grapple with because they are so difficult.
Similar to what Paige has mentioned, several of the speakers highlighted the need for a systems approach to combating AMR. And I think that just really strengthens the idea that we need a coordinated outreach and education to the stakeholders.
As always, I was very impressed by the things I learned today. And as I think about the work we have to do tomorrow,
I think of something recently quoted Arjun Srinivasan as having said, a frequent presenter here, which is, to be a good leader, you need to know when to lead and when to follow. And I think that we need to follow some of the great examples of some of our international colleagues that we saw today. And that's really going to be the tricky part for us as we go forward with this report.
So I think a key point that I took back home, or will take back home, is that we need to understand the context and the influences of the pressures, whether it be financial or social or cultural within the system, in order to create these interventions, to create lasting behavioral changes. And then kind of as an add-on, harkening back to the beginning introduction with Dr. Liao, just remembering stories like his sons, and when we're thinking about these going into our small group discussions and how we can really benefit a lot more people.
Yeah, we talk about challenges a lot, and I don't want to make it sound like that's an excuse to do nothing, but the fact of the matter is there is no one-size-fits-all solution that we're going to parachute in from a far-off place. And so I think the contextualized approach really struck me, and just the fact of the matter is that's laborious and slow, but that's what we're going to have to do if we want it to be successful across all the different various places and situations that we encounter AMR.
I think we all quote the 1.27 million number all the time, and drives home to me that really the targets really here are about mortality reduction. And so in order to achieve that, we're really going to need innovation, not only in treatment, which is where we often talk about innovation, but in prevention, and not just prevention in vaccines, but also in IPC and also in implementation. And all of those combined is how we get to that solving the access issues as well.
I also liked Courtney Price's little quip. The best way to fight AMR is not to talk about AMR, but to focus resources on prevention, diagnostic capability, and common diseases of humans and animals.
So I want to comment on the communications issue. I think we have a problem in that people can't see the problem we're talking about. We need our patient stories to give us that visibility. And so I kind of take issue a little bit with staying away from fear, because I think people need to be afraid a little bit to pay attention. And we need to bring attention to that. And so we need something else. If it's not going to be fear, we need maybe a celebrity. We need endorsement. Yeah, I don't know. I really liked participatory co-design, as many have mentioned. I've seen asking people about the type of ABHR they use and marking floors, things like that are critical to affecting change on a local level. And I really liked pooled procurement platforms, the idea of access. And I think stratified targets are essential coming out of this as part of our report.
Following on the idea that we don't need more information to act, I wrote a little rhyme here, which is we may not need more data to act, but we need to act based on reliable data. So knowing some might be sufficient to act, but we need to continue understanding and learning so we can know what's the best return investment.
I want to amplify a point that Libby made earlier on today in connecting one of the speaker's presentations with our patient story from this morning, is that when we talk about access and implementation, that we really want to pay attention to barriers at the really local micro level. I think that gets to a point people have emphasized already about the importance of context and tailoring, but just linking back to that story and about some of the tragic, failures in accessing needed care in a situation where, maybe we thought it would have actually gone through. And then the second piece sort of plays off what you were saying, is just the importance of being careful when we say things like we need more data, because that can actually be sort of an obstructionist or stalling technique. It's sort of how can we, in our recommendations, really move towards action and generating the political will to do things to change.
All right, now we'll go online for our three council members. So, Jim, maybe I'll kick it to you, and then I'm just going across my screen here. Robin, to you, and Claire, will let you go third. You're on mute, Jim.
Okay, thank you for the opportunity. It was an incredible meeting. Really enjoyed all the panels. The take-home message that I got out of the sessions today was the importance of integrated practices for prevention of bacterial infections and not just relying on the antibiotics for treatment. Also, the vaccination approach seems to be an underutilized practice. And we have to think not just about animals and humans, we have to think about the food supply and agricultural practices in producing the food. And so I'm talking about plant agriculture. So I think the systems approach is very important in communication to iterate these findings and how to prevent AMR from becoming a bigger problem than it already is.
Great, and I will comment as a diagnostician that I really appreciated the concept of alleviating diagnostic uncertainty. I think the patient perspective that people want the best drug, but they don't understand the need for diagnostics is important, that laboratory results are everything, as was stated, and that we need to make a proper diagnosis before treatment. And
so I also, as a diagnostician, that was exactly what I was going to say. So I get to say my other point, which was, I think I was really struck by the concept of health literacy. And, in my own experience working in this area, how do you not overwhelm people with messaging because they have to learn about so many other health related things? So how do you keep it very concise so that people can really have a high level of health literacy across many, many different areas of health, not just antimicrobial use? And so, I think that was kind of my take home message is how do you partner with other health topics to make this not just a barrage of information that people can absorb and might not find the value in.
Excellent. Well, I enjoyed that. That was a lot of fun to hear everybody's take homes there. I heard several words multiple times, so I was just writing those down as we kind of went. I heard innovation multiple times. I heard access multiple times from Jason, as well as multiple times from others. I heard context a number of times, communication, behavior change, co-design. And I think one of the things that strikes me about this, certainly there's this, innovation and development need that bridges even beyond antimicrobials, but into vaccines, into diagnostics and broad the ecosystem that folks mentioned. But I'm just struck again by really the component of social sciences here, right? And not only in the terms we use there, but even as we think about decision makers and stuff, a lot of that's behavioral science. How do people go about making decisions? How do we encourage them to make decisions and those types of things? And so I think we continue to appreciate social scientists and the context. Great panel there today, but as we talk about each of these things, we almost always are going back to how do we change perception? How do we change communication? How do we communicate such that people make changes in their behavior, whether that's prescribing in their policy or in their approach. And so I think those are critically important. As a council now, we get to take this information and dive back into our continued efforts around our report generation. And so certainly the working group and the council as a whole, we now have the opportunity to take what we've heard today and these take-homes and really challenge you to be thinking about how do we move those into actionable recommendations in the context that's unique and bring something new to the table and doesn't just necessarily echo the common sense type of things that we should all be doing already, but brings forth a new concept or a new approach that's actionable that we can make recommendations to the U.S. government around and the AMR community in general. So with that, any last comments, Dr. Musmar, from you? Dr. Newland told me he didn't have any additional ones. He said access 3 times. So.
I just want to thank everyone for joining us today. I encourage all of our working group members and especially our federal, our regular government employees to join us in person tomorrow for the working group session so we can try to consolidate and distill all of this information that we have, because my takeaway is we have a challenge ahead of us capturing all of this in a tight little report due in May. So thank you all for being with us. We conclude our 25th public meeting, and we will see you again in May, but with a report with the recommendations then. Thank you all. Have a good one.
That's a conclusion. Thank you.
Produced by the U.S. Department of Health and Human Services.